We're talking about pulmonology. The lecture today is about the ventilation perfusion ratio. So let's see what we mean by that. Ventilation, especially in the case of doing the ventilation perfusion ratio, ventilation is the alveolar ventilation. Remember that there are two types of ventilations. One is the minute ventilation. What is the minute ventilation? It is the amount of air going in and out every minute. So if our tidal volume is 500 milliliter and the breathing rate of a normal person is 12 breaths per minute, then the alveolar ventilation, the ventilation will be ventilation equals tidal volume multiplied by the frequency is 500 multiplied by 12 is 6 liter. So that is the ventilation, minute ventilation. However, the alveolar ventilation is what is important here. So please remember this, that for ventilation perfusion questions and for ventilation perfusion concepts, the ventilation type used is the alveolar ventilation, although everyone just says ventilation perfusion. Now, what is alveolar ventilation? I hope you remember that from our previous discussions. Alveolar ventilation is the tidal volume, so volume tidal, subtract the dead space. You know that normally about 150 ml is the dead space. So volume dead space, subtract them and then multiply it with the frequency. So that will mean 500 minus 150 multiplied by 12, and that comes to be about 4200 mLs, or let me just call it 4200 ml, about 4 liter. So for this lecture, the ventilation, whenever I say ventilation, I mean alveolar ventilation, and in a normal healthy person, what I mean is 4 liter per minute. Okay, so keep that in mind. That is the first thing. What we'll do in this lecture today is we'll look at the alveolar ventilation and the differences of the alveolar ventilation in the apex and the base. That is one thing to be done. Second is we'll look at the blood flow. If we understand these two, we will then also talk about some of the very important concepts that are related to the ventilation perfusion ratio. Look, a ventilation perfusion ratio of normal is not a very interesting thing for a doctor. However, when the ventilation perfusion mismatch occurs, that is when you should become alert and your ears should start looking at what is wrong. So it is, you have to catch the concepts that will be related to the ventilation perfusion mismatch. So let's talk about the ventilation itself, that what does compared to the apex and base, what is the difference in these. So look, what happens is that the apex of the lung, when a person is standing, we're not talking supine, supine is almost the whole lung is the same, but when a person is standing, what happens is, don't you think that the lung tissue is going to be trying to fall down while the pleura is keeping it hung up and the chest cavity? So now there is a lung tissue that is trying to go down while the chest cavity and pleura, the whole mechanism we discussed again and again, is trying to keep it up. What would happen as a result of that is, near the apex, the alveoli, I've made that over here, this is an apical alveoli. Near the apex, alveoli are larger. They are large and they are stiff. Why are they stiff? Well, if you inflate a balloon to its maximum, now it is stiff. At this place it doesn't have much more compliance. It would probably burst open, but it is maximally opened already, so it is not going to change too much until you allow it to become recoiled and decompressed. That's a different thing. But if you keep it open at that level, the change in it is not going to be too much, so it is stiffer. So alveoli at the apex are stiff, they are large. On the other hand, alveoli that are near the base of the lungs, the lower part of the lungs, are under higher pressure, because of the lung volume is pressing on them, these are smaller in size. These are smaller in size. Now, smaller alveolus, is that a bad thing? That is actually a better thing. That's actually a great thing. Look, imagine that this is the alveolus at the base and this is the alveolus at the apex. Which one is more compliant? This one. Do you know why? Compliant means which is easily distensible. Well, this is already inflated. It's not going to distend further. Is that a bad thing? You say, well, it is already inflated, has a lot of air, we're all good. No. If it is not going to move, it is not going to receive new air in it. It has to open up to receive the air. For example, this alveolus, if it is present at the base of the lung, I have a lot of space to push the air in it. Right? I have a lot of space to push the air in it. If this was also this big, then how much more air could I push? Just tiny amount. So remember this, that the alveoli at the base, because of the pressure, gravitational pressure of the tissues around it, these are smaller in size. Smaller also means that they are more compliant. Compliant means they have a lots of room to expand. So if this is the normal small size, alveolus can go from here to here. Over here the alveolus can go a little bigger as well. So here the total difference in expansion is this, while here you can expand all the way to this big size. So do you think that with one inspiration, what do you think, with one inspiration, which alveolus would get more air? Of course at the base. So in a standing person, the alveoli at the base, they receive a larger volume of air and they are better compliant. Now how about the blood flow compared to apex and the base? So before we do that, let's look at the zones of blood flow which can happen in the lungs. For the blood flow zone, what is important to note is this. There are three types of possible blood flow zones in the lungs. One is where alveolar pressure, I'm going to talk about the flow, but first we have to look at the pressure and resistance so that we can look at the flow. Alveolar pressure is greater than the arterial pressure. Which arterial pressure? So pulmonary arterial pressure, it represents the systolic pressure, is greater. So this is arterial pressure, this is alveolar pressure, is greater than venous pressure. And what does that mean? What that means is that the alveolus has so much pressure in it that it is compressing on the blood vessel, and at all time during the systole, when the pressure actually in the blood vessels increases, or during the diastole when the pressure actually falls. In both cases alveolar pressure is higher than both of these. In this case, this blood vessel will never open up. Why? Because alveolus will keep it pressed down and closed. This zone 1, this is called zone 1 flow, zone 1 flow. Now what do you think the flow will be here when the vessel is closed all the time? Zero flow. It does not occur normally, it is always abnormal. What are the causes? For example, hemorrhage. Hemorrhage would cause so much of the blood loss that the pressures of the blood will reduce so much that alveolar pressure would become higher and these blood vessels will not open up. Now let's also look at, this can also happen with the positive pressure ventilation. So when we are doing PP ventilation, if by mistake we increase the pressure too much, then we can end up with the zone 1 areas of the blood flow, meaning zero blood flow. Zone 2 blood flow is where the alveolar pressure is higher, arterial pressure is higher than alveolar pressure, which is higher than the venous pressure. So here when the heart goes in systole and the arterial pressure raises up, that is when the blood vessel will open up. And when the heart goes in diastole and the pressure falls, now the alveolar pressure becomes greater and the blood vessel will collapse. How would it collapse? Because the alveolus would press on it. This is called zone 2. Zone 2 flow. What do you think the flow will be in this one? The flow will be intermittent. With every systole, the blood vessel would open up, and with the diastole it would collapse. During the opening it would have the blood flow and then close. So with every heartbeat you would see blood come in and stop, come in and stop. This is what happens at the apex of the lung. At the apex of the lung, zone 2 blood flow is present. Okay. Then let's go to the zone 3. I think you can now figure it out by yourself. In the zone 3 type blood flow, what happens is that arterial pressure is greater than venous pressure is greater than alveolar pressure. So that means the blood vessels in this zone will always be open during the systole or diastole. So normally if this is the heart here, somewhere over here, about 10 centimeter above the heart is the zone 2 that starts in the upper part of the lungs. And then from 10 centimeter above the heart to all the way to the bases is the zone 3. That is continuous flow. Okay, so we're done with the flow and we're done with the ventilation. Can I then plot these two over here, and can I say that compared to apex and base, and one more thing for the apex and base, the pleural pressures, if we look at those as well, at the apex the pleural pressure is minus 10 centimeter and it raises up to minus 13 centimeter of water, H2O. Again, lungs are hanging at the apex with the against the gravity is pulling it down. So when that hanging is happening, the alveoli are stretched open. On the bases though, the pleural pressure is minus 2 centimeter and it can go up to minus 5 centimeter of water during the inspirations. So the pressure, pleural pressure is smaller here compared to here, but even then we have talked about, because the alveoli are stiffer, they move less here compared to at the base. So most of the ventilation is done starting from the 10 centimeter above the heart and all the way down to the base. Okay, now let's plot this thing over here. At the base, so this is the base and this is the apex. What do you think if we talk about Q? Q is the flow of the blood. At the base, is there higher flow compared to at the apex? Yes. So higher flow at the base compared to apex. What do you think will be the blood flow? So this is the Q is the blood flow. What about the ventilation? Ventilation, again, both are higher at the lower end and lower at the upper end, but they change like this. It shouldn't be like a straight line, so let me make them a little more steeper. If we put the right data, then it's easier, but for our process here, like this. So now what is happening is, at the apex both the flow and the ventilation is lesser. However, at the apex what we are saying is ventilation is more than the flow. Why? Because alveoli are bigger and open. At the base we are saying both flow and ventilation are higher. However, at the base, once again, here the flow is higher than the ventilation. Got it? So keep this in mind as well. Let's talk about the ventilation perfusion ratio, how to calculate it and how to understand it. So look, what happens is, we'll take this is the base of the lungs. Alveoli are smaller, arteries or vessels are bigger. At the apex, alveoli are bigger, blood vessels are smaller. Apex is the higher resistance area for alveoli, base is lower resistance area for apex is the higher resistance area for blood vessels, and base is the lower resistance area for the blood vessel, because blood vessels are distended here. Okay, we'll take somewhere in the middle of the lung. Why is middle important? Because this is somewhere where ventilation and perfusion, they are both matched the best. So here we know what is the ventilation. The ventilation, again, as we did that in the beginning, ventilation is the alveolar ventilation. It is about 4 liter per minute. So we breathe in 4 liter per minute, alveolar ventilation, not minute ventilation. Minute ventilation is 6 liter per minute. but we have to remove the dead space from it. We talked about it before. So alveolar ventilation is about 4 liters. Divide that with the cardiac output per minute, that will be the flow, right? So the right heart's output is the flow of the lungs, and normally about 5 liters per minute. So 4 divided by 5 is about 0.8. So that is the normal ventilation perfusion ratio. How do you talk about it? What does 0.8 mean to you as a doctor? What it means to you is this: with this amount of perfusion and breathing, we are able to keep PCO2 or pressure of carbon dioxide to 40 millimeter of mercury and pressure of oxygen to 100 millimeter of mercury in the alveoli. So I should put A here and A here. That is what it means. And you say, well, why do I care? Yes, we don't care if it is normal, but if this becomes mismatched, if this goes up or down, you can clearly see. Let's say if I increase the PaCO2 in the alveoli, if the carbon dioxide level in the alveoli goes up to 60, how can that go up to 60? Reduce the breathing. So when I reduce the breathing of a person, carbon dioxide levels would increase. That would mean what? pH would start reducing, right? Carbon dioxide has a relationship with the pH, and what is that relationship? Carbon dioxide plus water make H2CO3, which makes hydrogen ion and bicarb. This hydrogen ion participates in creating pH, right, or acidity. So if you have more carbon dioxide, then the pH will become lower, or the body is becoming acidic, and the other way around. So that means when this becomes abnormal, we have an interest in it. Similarly, when the oxygen levels become abnormal, if they go down, we have a hypoxemia. If they go up, well, we don't really care too much. So this is important as the mismatch happens. Now let's look at normal person's apex. At the apex, as you can see, these alveoli, we talked about it, they are less compliant. They don't receive too much air, and they receive very less fluids as well, or the blood as well, because their vessels are less distended, they are high resistance vessels, and they are low pressure vessels. So what happens as a result of that is that the ventilation over here is higher than the flow. Ventilation is higher, relatively higher than the flow. So when you increase this from 4, if you make it 5, what will happen? 5 divided by 5, it would become 1. So can I simply say, when the ventilation perfusion ratio becomes greater than 0.8, that would mean that there is more air coming in and less blood to pick it up. This is called dead space. Dead space is, and remember, space, it should be working space. The alveoli are working, they are present, they are connected all the way to the outside. It is not that you have obstructed something in the airway and stopped the airway from working. That is not dead space. That's a different kind of a space. We'll talk about it. This is the dead space where alveoli are connected all the way to the outside. However, the blood that is flowing to pick up the oxygen and give the carbon dioxide is less. So now the ventilation perfusion ratio, or the VQ ratio, is greater than 0.8. What would that mean? What do you think about PaCO2? When there is less blood coming in and there is more of the air coming in from outside, PaCO2 would start reducing. How about PaO2? Oxygen level, of course, would start increasing. What would happen to the pH to this side only, pH here? pH will increase. Why? Because CO2 is reduced. Reduced CO2 would combine with water less, would produce less hydrogen ions, and the pH will be reduced. Now at the base, what's happening is there is more flow. than the air that can come in. So now the situation has become different. This lower side, the flow side, has become higher. So if it is 4 by 5, now it may be, let's say, 4 by 6 or 3 by 5 or something like that. So the end result is the ventilation perfusion ratio will start becoming lesser. So less ventilation perfusion ratio means what? What it means is that there is more blood flow and there is less air available to exchange gases with that blood, with all of that blood. This is called a shunt. Shunt is a situation where blood comes to a piece of lung, so let's say this is lung, and goes out from the other side, and only a part of the blood works in the gaseous exchange, rest of the blood just continues on. This is called the blood is shunted. Blood is shunted, and this is a right to left shunt because the blood from the right side is coming in and going to the left side, coming into the lung and then going to the left side. So the result is the shunt is 0.8 and lesser than 0.8. Now what do you think would happen to the alveolar carbon dioxide in this case? So here we have the shunting going on. PaCO2 would come in, there is not enough flow happening, there is not enough gaseous exchange happening because the alveolar surfaces or alveoli are not sufficiently available. So carbon dioxide that would come in would go out. Similarly, the carbon dioxide will be sticking here as well because more blood has given PaCO2. So PaCO2 levels would increase. What about PaO2? These levels would decrease. What about pH? pH would increase. Sorry, I always do that. pH would reduce, acidity would occur. So this is what is happening at the bases of the lungs. The last part of this topic, and that is how do we evaluate and generalize when we get the values of the ventilation perfusion ratio. So let's say if I said to you that there is a patient who has VQ ratio of lesser than, let's say, 0.7 versus a patient who has VQ ratio of 1.2. What does this mean? What is the comparison? So let's look at it first. If the VQ is reduced, what does that mean? Ventilation over perfusion. And when it is reduced, that means the perfusion is more and ventilation is less. So this lung is underventilated, number one. Number two, if it is underventilated, blood is coming in, there is not enough oxygen and carbon dioxide to work with, and blood is shunted away. So when it becomes fully underventilated, when there is zero ventilation, let's say there is an obstruction in the alveolar somewhere and the ventilation is zero, then this is a shunted blood, fully shunted blood. But when the obstruction is not full and there is some blood that is still flowing and there is some air that is still coming in, then we'll say there is a component of shunt present. As I had discussed here, there is less gases present, more blood is present, so the less surface area to exchange the blood gases, so there is a component of shunt. If you close this airway all together, so let's say if I make one more here, now this airway is closed. Now the blood that is passing from here is fully shunted, 100% shunted. It is doing no work. So underventilated, either fully shunted or has a component of shunt, and in the hypoxemia discussion we'll talk about it, that if this goes to zero, then that would mean that the person is developing hypoxemia, or underventilation starts contributing towards hypoxemia, less oxygen in the blood. Now let's look at this. You see another patient, and that patient has a ventilation perfusion ratio of 1.2. What does that mean? Ventilation is more and perfusion is less. So how do you generalize? How do you evaluate? Here is how you think about it. You say this person's lung is overventilated. More gases and air is coming in, but less is being picked up by the blood. It is overventilated. That also means there is a dead space component attached to this. What does that mean? That means that the alveoli are connected with the outside, gases are coming in here, but the blood flow is either very less or absent. So the gaseous exchange is not happening or happening in a reduced way. So if it is not happening at all, then you say that this has become a dead space. If it is happening a little bit, then you say there is a component of the dead space. Look, this is what's going to make you the smart doctor. You'll say, well, I think there's a component of dead space involved over here, so let's evaluate that. So that's what's happening. So this is how. Now one more thing, overventilation does not create hypoxemia. If I give too much ventilation into one area of the blood and the blood flow is still the same, or if I give normal ventilation but blood flow is less, this would not contribute to hypoxemia as much as underventilation would create hypoxemia. Cool. So that is the lecture today. I would like one more thing to be discussed. It's a bonus concept here, and that is what happens to the pulmonary blood vessels in hypoxic situations. Now, in our normal tissues, when there is hypoxic situations, then the blood arteries open up, they dilate to bring more blood there. However, in the lungs, bringing blood to an area which is hypoxic means that has less oxygen and carbon dioxide received, less gases are coming in. Do you think it is useful to bring blood to an alveolus that is closed? No. So lungs are smart. What they do is they close the blood vessel where there is no gaseous exchange happening. How does that happen? So lung have a paradoxical arterial behavior, and that behavior is that the blood vessels constrict under hypoxia. So let's look at that very quickly. Let's say that this is the blood vessel, and this blood vessel of course has artery, it has arterial wall. In that wall there are smooth muscles. So if I take one of the smooth muscles out and put that over here, the way this works is that the potassium channels on this smooth muscle of the arterial wall, these channels have something very interesting. They are oxygen sensitive, O2 sensitive. So when oxygen binds with them, they open up, and when they open up, that causes the potassium to leak out, and when potassium leaks out, then there is the normal resting potential that is created. So now when the oxygen is present, then the potassium ions are moving out and the resting potential is there and the muscle is moving normally or acting normally. If for some reason hypoxia happens, the oxygen is absent, so either the patient is in an environment where he cannot receive lots of oxygen, or the oxygen is coming in but it is not going to that part of the lung. For example, there is an obstruction in the airway, end result is there is no oxygen here. If that happens, then this channel closes down. When this channel closes down, potassium gets stuck in. Positive staying in, remember potassium normally leaks out. When the positive starts staying in, that increases the cell's positivity and the cell depolarizes. Now a depolarized potassium muscle cell will move la 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 continuing. So cut that part. Now a depolarized muscle cell will mean what? It will mean constricted muscle cell. Constricted muscle cell will mean that this blood vessel will now become closed. It is closed. So when there is less oxygen, the blood vessel will become closed. That is the effect, that is the paradoxical behavior of the pulmonary vessels to hypoxia, and that is that they close down, and that is how the lung shunts away the blood to some other parts and tries to pass the blood from the area where the gaseous exchange can happen. Thank you.